talking about drowning this evening. And the reason being is it is the summer months, and we are seeing more of this, but also because we did have a case recently, and I think it's important for us to sort of highlight some of the topics. Okay, so there's a little bit of confusion when it comes to terminology. And there's a lot of old terminology that you might find in the literature or online, or when you talk to people. So you might hear saltwater drowning, freshwater drowning, near drowning, dry drowning, wet drowning, secondary drowning, active drowning, passive drowning, delayed presentation of ARDS, all these terms. And all of these terms are outdated. Actually, it's become much more simplified recently. AHA released some documents on drowning within the last few years. And there's been a lot of research since the beginning of the 2000s, looking at sort of Utstein style classification, so that when we are talking about deaths or morbidity from drowning, that everybody is using the same terminology. Because if you say near drowning, it gets confusing. Passive drowning, no one really knows what we're talking about. Okay, so I'm going to put it out there. Does anybody know what the definition of drowning is? Hello? I think I'm talking to myself. Does anyone know what the definition of drowning is? Okay. All right, I'm going to jump in then. Okay, it's the process of experiencing respiratory impairment from submersion or immersion in liquid. Doesn't have to be water. Submersion, that is when the upper airway is underneath the surface of the liquid. And immersion is either where the upper airway is above the surface of the liquid, or liquid is splashed across the face, for example, in waterboarding or other circumstances. Fatal drowning is where the drowning event is associated with a death. That's the outcome. Non-fatal drowning, there's a drowning event in which the process of respiratory impairment is interrupted prior to death. And a rescue is where there's some sort of intervention that occurs that prevents progression to drowning, and at no time is there any kind of respiratory impairment, even down the line. Okay, so there's a classification for drowning, and this was proposed in 2012 in the NEJM article by a group of researchers. Looks fairly complicated, but you'll see on the far right-hand side, there is the rescue. On the far left-hand side is the death, and in between there's grades 1 to 6. Essentially, the grading just looks at respiratory and cardiovascular symptoms. And it's actually has been simplified even more since that classification. So we either have a rescue where there are no symptoms whatsoever and the patient is asymptomatic. We have a fatal drowning on the other side. And then we have a non-fatal drowning in the middle, mild, moderate, or severe impairment. A mild, there might be mild respiratory symptoms, moderate, potentially moderate respiratory symptoms, requiring some kind of ventilatory intervention. Severe is severe respiratory pathology with or without hypertension, or even respiratory arrest or full cardiac arrest. So the previous slide with the grading can actually be fitted in here, but this is the best way to understand drownings. And when we're talking about drownings and diagnosing drownings and classifying them, we should use this as our framework because it makes things much simpler. Deaths around the world, we've got a lot in low, middle income countries, quite a significant amount of drownings also in the Far East. Drowning causes 1/3 of unintentional deaths worldwide. And unfortunately, a lot of these cases are kids. The the unfortunate stat is that it's estimated that about 90% of drownings are actually preventable. 90% also of the unintentional drowning deaths around the world, as I mentioned earlier, occur in low-income countries and low-middle-income countries. And when we have flood disasters, up to 75% of the deaths are from drowning. So what about South Africa? We had a recent publication released in 2022, looking at statistics of fatal drownings from 2016 to 2021. And we can see that KwaZulu-Natal is probably the most prominent province with the highest number of fatal drownings. The coastal provinces have much more drowning incidents because they have higher access to bodies of water. But horribly, you can see in the middle there, Gauteng still has a fair number of deaths. That is worrisome considering we are completely sort of logged. We're completely surrounded. We're not exposed to any specific seas or massive dams. Most of our drownings, unfortunately, occur from rivers. So some other statistics from South Africa, the circumstances of the drowning, the bulk of them are fresh water. The next is pool or swimming pools, the ocean, in and around the home, and other. So in and around the home includes kiddies that will die in the bath or in a bucket of water or land in a puddle face down. According to the age groups, children unfortunately have much higher mortality rates, and the very small, so 0 to 4 years, and the 10 to 14 years also have pretty high mortalities. And they actually have the biggest mortalities in South Africa. And this is in keeping with other international statistics. So around the world, kids, unfortunately, and the younger age group are particularly susceptible to drownings. What about how many average fatal drownings do we have a year in South Africa? 1,477 is the statistic that was captured as the average for the last couple of years. Unfortunately, there are a large number of unreported deaths, especially if bodies are not found or recovered. Males are much more likely to suffer fatal drowning than females, and this is true internationally and in our literature as well. Months of the year, it's usually summer months, and in South Africa, January and February are the biggest danger times, and November as well. When are the drownings happening? Unfortunately, over the weekends. Sundays are the biggest threat, and then Saturdays. And the most risky time for deaths to happen in South Africa between 4 and 8 p.m., so sort of in the afternoon and early evening. What are some of the risk factors that lead to drowning or to fatal drowning? Well, if there's inadequate adult supervision and kids are around bodies of water alone, so if somebody's doing washing in a basin and kid is unfortunately around the basin and the adults are not there, it's very easy for a child to be exposed. Patients that can't swim, unfortunately, or have got very poor swimming skills, have got a high risk, as well as athletes who push themselves to the maximum and might overestimate their swimming capabilities or put themselves in dangerous circumstances. So it's much less death happens in that group of people. It's much more likely in people who can't swim, but it is also athletes who will push themselves beyond their limits. Risk-taking behavior, especially in adults, alcohol is commonly involved in drownings. Hypothermia, which can lead to dysrhythmias and exhaustion. If a patient has got other concomitant illnesses or trauma, for example, if they've had a stroke or an MI, that might precipitate the drowning. If you have a seizure disorder, there's a 20-fold increased risk in fatal drownings, especially in kids and adolescents, but the same goes in adults. If you have a developmental or behavioral disorder, something that's not mentioned on the slide, if there's a mood disorder and if it's an intentional drowning, so a method of suicide. Sometimes patients, there doesn't seem to be a good explanation for why they drowned. They might have had a undetected cardiac dysrhythmia, for example, a lung QT syndrome. These can't be functionally diagnosed anatomically because they are related to the channels in your heart, and these unfortunately cannot be seen at autopsy. Hyperventilation prior to diving can lead to drowning, and patients who belong to a poor socioeconomic group, education unfortunately is involved, as well as ethnicity too. Mentioned kiddies have a high risk of falling into buckets, but toddlers in particular, because their center of gravity is different. They've got relatively big heads in comparison with the rest of their body, which makes them top heavy. And this is unfortunately how we often get our children presenting, as they've drowned in a bucket. The literature across the board has a look at the submersion time, and the submersion time is directly related to the outcome. So a short duration, you have a better chance of survival, and the mortality is about 10%. So if we look at survival and mortality, these stats are also based on if there's severe neurological impairment. An intermediate duration, somewhere between 5 to 10 minutes, is related to a 56% mortality or severe neurological impairment. If it's 10 to 25 minutes, this is obviously still a longer period, but the more recent literature is just looking at a short duration, prolonged drowning, and an intermediate duration. So the longer the time frame, the higher the likelihood of death. And a prolonged submersion or immersion where the patient has drowned and has been underwater for more than 25 minutes is related to pretty much 100% mortality. So it's really important for us to try and flesh out how long do we think the patient was submerged, and when were they last seen alive? When can we pinpoint the last time that they were seen to be moving and walking and alive? So there was a lot of research over the years looking at freshwater versus saltwater, and a fair amount of time and energy was spent looking to see what the differences between freshwater and saltwater drownings were. But the salinity of the water is not really important, and that's been confirmed by the more modern literature. Both saltwater and freshwater drownings, actually drowning in any liquid, cause lung injury. So if you are immersed in fluid or submersed, there are a few things that will happen. You get sympathetic activation as one panics and you have a fear of drowning. So this increases your heart rate, increases your blood pressure, increases your anxiety levels. Initially, when we get water hitting our airway, we might cough, and also will be stimulated to hold our breaths. The water in the upper airway also might result in a laryngospasm. And you might aspirate a small volume of water initially. And all of that will lead to hypoxemia and hypercapnia and acidosis. And as the CO2 levels rise and the acidosis sets in, this actually causes a significant drive to breathe. It's quite a significant stimulus. Sorry, my cat is jumping around in the background. Emmett, naughty. All of these things eventually will be overcome. Eventually, the laryngeal muscles relax. Also, during immersion or submersion, there can be a lot of swallowing. So swallowing reflex, as we swallow and ingest fluid into our esophagus and stomach, that usually also closes the upper airway. It's like a protective mechanism when there's fluid in the mouth. But that can also lead to emesis, so vomiting. At the beginning of drowning, there's sort of like an easy going phase during breath holding. So where the person doesn't have significant inspiratory muscle contractions. And there reaches a point where a person can no longer hold their breath, and they have significantly increased urge to breathe. The inspiratory muscles contract. It's an involuntary reflex. The airway opens, and it's quite difficult. And so this is the struggle phase. So, and the break point that they're talking about is the point clinically where a person is no longer able to hold their breath. And that's called, that's essentially when you'll be taking a breath as well. Okay. So this is just a pictorial diagram from Netta showing the initial laryngospasm that you'll get, and then the larynx that is then found, and it's usually found in the open position after prolonged submersion because everything relaxes, there's significant hypoxemia, and the patient eventually goes into a cardiac arrest. He's tried to show some of the features that might be found on lung, so significant atelectasis with a washout of surfactant, with collapsed alveoli. There might be a fluid-filled segment with significant consolidation and fluid having damaged the lung tissue and fluid-filled alveoli. The patient also, because of the large volume of water that it might be swallowed, can cause gastric regurgitation, and there might be gastric aspiration as well. So gastric content in the airway might be found at postmortem too. Break points for breath holding. This is what I was trying to describe, that there reaches a point where you can no longer hold your breath and you are going to take a breath. So there's different kinds of settings where you have different break points. So the line depicted by the A on the graph at the bottom, that is somebody who has been breathing a hypoxic mixture, a gas mixture, so a 15% oxygen mixture. Their breaking point happens much sooner at a lower CO2 level, and it just means that they are stimulated to breathe much sooner. This graph B is somebody who's hyperventilating before they're diving. They are also more likely to reach their breaking point sooner, so at a lower CO2 level. C is normal breakpoint, so sort of a physiologically normal person. And D is somebody who has been inhaling a superoxide or, a superoxygenated gas. So here it was a 30% oxygen mix before diving. You can see that it increases the time to hypoxemia. And this is not an unfamiliar concept. We use this all the time when we are intubating a patient and we're pre-oxygenating them. We're trying to increase the time before there is a problem. So here, obviously, this increases the time before they take a breath and aspirate water. So what about the fluid? So the quantity or volume of the fluid that is aspirated is much more important than the composition of the fluid. So a lot of the old literature looked at saline or hypertonic fluids or fresh water and made a big fuss about that. An aspiration of 1 to 3 moles per kg of any liquid compromises respiratory function. And 2.5 mils per kg of aspirated seawater increases the shunt fraction by more than 75%. So that means there's significant pulmonary shunting. There is a small amount of data that does seem to show that saltwater drowning that results in cardiac arrest seems to have worse outcomes. And patients that drown in fluid with a high pathogen load, for example, sewage, stained waters, or actually a sewage tank, have a much higher risk for infection and sepsis. And that makes a whole bunch of sense. This diagram is pretty busy, but it's just describing two different things that might happen during a drowning exposure. In particular, we need to look at the temperature of the water because that also has an effect on the physiology. It is quite rare for there to be hot water drownings, although not unheard of. So in spas or Japanese soaking baths, there have been hot water drownings described, and there's different physiology related to that. But most of the drownings that we're exposed to in clinical practice, the water temperature will be colder than the ambient temperature of the patient. So the patient becomes hypothermic. So first of all, what can happen when a person is submerged in fluid that is colder than their ambient temperature is a diving response. And a diving response, for example, is if you splash cold water on your face and you wait and you hold your breath, you get a parasympathetic response. So you hold your breath, mainly you get a bradycardia, and this is because of parasympathetic stimulation. However, there's also autonomic conflict that can happen because there's this term called cold shock response. So if a patient is exposed and immersed or submerged in cold water, you also get a stress response, so sympathetic stimulation, and a patient can get a tachycardia. At both stages, whether there's parasympathetic dominance or sympathetic dominance, it will be difficult for the person to hold their breath. And eventually there will be a point where the person can no longer hold their breath. But this is just describing how there is an autonomic conflict in a drowning, but particularly in a cold water drowning. What usually happens in a fatal drowning is the patient becomes bradycardic and that there's a PEA arrest. However, there can be other circumstances that cause tachycardias, especially if the patient has got some underlying cardiac condition. Whether it's diagnosed or undiagnosed, they're much more likely to have effects from sympathetic stimulation. So if the patient's got a channelopathy, if they've got ischemic heart disease, if they've got some kind of drug-induced sympathetic stimulation as well, then the sympathetic effects of the cold water immersion might be more prominent, and they can have a ventricular tachycardia, a ventricular fibrillation, and this is more commonly found in cold water immersion than in ambient water temperatures or hot water drownings. So just a little bit more about what happens in the lungs. Once the airway is open and we aspirate, there doesn't have to be large volumes of fluid that are aspirated into the lungs. Sometimes there are big volumes, but it doesn't have to be a large volume. And the patients, as they're drowning, they really struggle. It's hard to see that someone is drowning. They might be vertical in the water, just sort of struggling to keep their face and their mouth above the surface and to breathe. They might also be face down and horizontal just underneath the water, and they usually can't shout for help if they are drowning, and they don't really have energy to be of assistance in getting themselves out of the drowning circumstance. So it's not drastic like it seems in the movies. Actually, drowning can be fairly quick and quite quiet. You have to be very mindful if you are swimming with children or people who aren't very good with swimming. So what happens? The fluid now goes into the lungs. The surfactant is washed out, and this can cause significant atelectasis. And now the surface tension in the lungs decreases as we no longer have that surfactant. The fluid then actually goes and destroys the alveolar capillary membrane. There's increased permeability, and there's leakage across the membrane. This causes significant pulmonary edema. The fluid hitting the lungs can cause bronchospasm, much like hitting the upper airway can cause a laryngospasm. What happens now from there is there's atelectasis, there's intrapulmonary shunting and VQ mismatch, as well as decreased lung compliance. And all of this leads to a worsening hypoxemia. If we are not able to rescue a person, this then can obviously progress to bradycardia, PEA, and cardiac arrest. If the patient does survive, they get rescued and they're brought through to the hospital. There's a number of systems that can be involved. If it's a rescue, there are no symptoms whatsoever, not even coughing. So asymptomatic is a rescue. Multi-organ dysfunction can occur for a number of reasons. Significant acute lung injury, and we've just gone through that. And the hypoxemia itself can cause multi-organ dysfunction, including cardiac dysfunction, neurological dysfunction, dysfunction of the kidneys. The abdomen, the patient very well might swallow large volumes of water and sand, and this can cause problems, can cause emesis, can cause perfusion issues. As the patient becomes hypoxemic, we can develop cerebral edema and have infarcts or hypoxic ischemic brain injury. There might be fluid in the sinuses. If there's trauma, There might well be fractures of the spine. The patient can go into multi-organ failure, including renal failure, hepatic failure, and failure of all their systems. Hypothermia itself is a consequence of drowning, particularly in South Africa, because even though it's warm waters, the temperature is still cooler than the patient's natural temperature. Hypothermia can be neuroprotective if the patient is hypothermic prior to the drowning. So temperature management is vital. We very well might have a patient who is drowned who's also incredibly hypothermic. And this is a problem because heat loss affects enzymes, hormones, action potentials. So therefore, it has effect on cardiac, nervous tissue, and muscular tissue. And we are not only dealing with the consequences of the drowning and the acute lung injury and cardiac injury, we're also dealing with concomitant respiratory and cardiac malfunction due to the low temperature. The hypothermia can further worsen the acidosis, and if there's trauma, this can also compound coagulopathy. So we do need to rewarm our drowning patients to a temperature that is compatible with life, which is above 32. If you've hit the above 32 mark, you know you're in the sweet spot. Obviously, it is nicer to rewarm patients to above 34. So that's why literature will describe between 32 to 35 degrees Celsius. Above 34, there's no shivering. So we do want to rewarm our drowning patients. What about what happens in the brain? Well, more than 20% of the non-fatal drownings have got severe neurological damage, and that's usually from the hypoxia and the ischemic injury. Obviously, we're worried about functional recovery, and if you have got severe brain injury subsequent to the drowning, this is a poor outcome as well. It's usually caused by cerebral edema, and the ICP might not be initially found on your initial brain scan. It might only be observed on subsequent scans down the line. And if you do find cerebral edema is developing, it's not usually the cause of the drowning. That's usually just an indication of the ischemia and the neurological insult that is developing. So it just gives you an idea of the neurological state of the patient. Patients present with seizures, which might be myoclonic jerks, seizure activity, but please don't forget then they very well might have non-convulsive status epilepticus, and that can only really be diagnosed on an EEG. So for us in the ED, we have to be aware of this and think about seizure prophylaxis. The neurological status very often can worsen once the cerebral edema sets in, but there can be some recovery with really good ICU care. So despite an initial poor examination, you can't necessarily use that as a prognostic indicator for what is going to happen with this patient. There are some very few case reports that show patients who were hypothermic that then fell in the water and drowned had a good outcome, but that is the reason it appears in literature is because it's fairly rare and the circumstances weren't the standard. Usually if there's a drowning and the patient has had significant brain injury, the outcome is not so good, but we don't know and you can't prognosticate initially. So, and also there's other things that might compound your prognostication. So if the patient was intoxicated with alcohol or drugs, the hypothermia itself can make it very difficult. So you can't see nice pupil responses. There's severe metabolic derangements from the drowning and from the hypothermia. So you need to be aware that it's difficult to prognosticate at the beginning. First aid stuff, we don't do the Heimlich maneuver to get water out of the lungs. You'll often see stuff like that in the movies. It's not indicated. It's a waste of time. And actually, we need to be providing ventilations to our patient. If you don't have anything with you, please just remember that 21% is better than 0%. So if you need to do mouth-to-mouth resuscitation, or face mask, pocket mask, ventilation for a survivor or a patient that you've pulled out of the water, this is the best thing. Ventilations save lives. So when it does come to CPR, we don't want to do hands-only CPR. If you're looking at the first aid situation, this is a situation where it's really important to get breaths into the patient, whether it be just rescue breaths because they've got terrible breathing or respiratory arrest, or they're actually in a full cardiac arrest and you need to CPR and provide ventilations. So this is a really important concept. EMS very well might have done some advanced interventions. The lifesavers will have done the first aid, probably started the CPR. EMS very well might have intubated the patient on scene, applied PEEP, done CPR, got ROSC, and then brought the patient into you. So just try and get a really good history to find out what the circumstances of this resuscitation were. So what do we do when the patient hits the door? Well, if it's a rescue, those patients that are absolutely asymptomatic, there's no coughing, no symptoms whatsoever, those patients can probably be monitored in the ED for 4 to 6 hours and discharged home if there's no problems. If the patient has got mild symptoms, so they very well might be coughing, but their SATs are okay, they don't have any increased work of breathing. Maybe you hear some soft crackles on auscultation. Maybe you don't. It just depends on the severity of the presentation. These patients probably do need to be observed for longer. So kids, 6 to 8 hours, which in our setting would mean the patient needs to be admitted to PEDS short stay ward and monitored in case they show later signs of acute lung injury from the water that's aspirated. The same basics go to everybody. So get them out of the wet clothes. If there's trauma, look at C-spine precautions. But if the patient is in cardiac arrest and you're having difficult ventilations or difficult airway, that takes precedence over C-spine. Consider non-accidental injuries, especially in children. And don't forget that what might be causing the drowning in the first place. Is the patient hypoglycemic, having seizures, a dysrhythmia, or something else that's going on? A patient who presents with moderate drowning symptoms has got respiratory compromise. Their SATs are lower and they've got an increased work of breathing. They need supplemental oxygen. So it might be just a low flow oxygen with a nasal cannula or a face mask or a polymask, or they might have severe respiratory compromise where they actually need further respiratory support in the form of high flow nasal O2 or CPAP NIV. These patients need obvious admission. You do need to look at the temperature. You're going to need to get IV access for them, chest X-ray, ECG, ABG, and they need to be admitted for monitoring on oxygen. Obviously, if they're on CPAP or NIV, they need to be admitted to a high care ICU environment. High flow nasal can be administered in a ward. Okay, if they come with a severe drowning, that means that the patient has got severe respiratory compromise, even potentially respiratory arrest. They need actually airway intervention usually in order to facilitate the respiratory interventions. They also might be profoundly in profound respiratory distress with hypotension, or they very well might have no pulse whatsoever. So these patients will need ventilatory management. You have to do positive pressure ventilation, and this is the one time that you will probably give PEEP in cardiac arrest. This patient will need intubation, so you need to secure an advanced airway, and it has to be an ET tube. It shouldn't be a supraglottic airway device unless you can't intubate, but these patients do need a ET tube, and they need positive pressure ventilation with a good PEEP on a ventilator. If they're bradycardic, if they're children, you need to start CPR. If there's cardiac arrest, adults or kids, obviously CPR, IV, or IO, look at getting central access, fluid bolus, depending on the cardiovascular status of the patient, and looking at vasopressor inotrope support. Temperature management is very important in the severe group. So you need to get a core temperature, which is difficult because the thermometers that we usually have are tympanic at best and don't necessarily read low. So you actually have to have an esophageal or rectal thermometer. You need to rewarm these patients to 32 to 35 degrees, and you need to manage shivering, and shivering usually disappears from below 34 degrees. So with shivering, you very well might need to add benzos, you might need to add pethidine. It's quite good for preventing shivering. Seizure management, particularly if you're intubated, unconscious, comatose, we won't necessarily see if there are subtherapeutic or subclinical seizures. So load with an anticonvulsant, we have phenytoin. And obviously down the line, the patient will need EEG monitoring in ICU setting. This patient needs much more investigation. So we'll need bloods, including a CMP, an albumin, maybe a CRP as a baseline. If you are worried the patient has been submerged in sewage, blood cultures, antibiotics might be considered for those patients. For post-resuscitation care, you look at your post-resuscitation algorithm and look at neuroprotection. The patient is going to need a CT brain with or without a C-spine, depending on the mechanism. So if there was trauma, please consider EFAST and doing a full trauma workup. Patient also might need ongoing organ support, so not just cardiovascular and respiratory support, might end up dialyzed, might need assistance for GIT malfunction. And the patient who's super unstable in a private setting very well might need to go on to ECMO. So VV ECMO for respiratory support and VA ECMO for cardiovascular support as well. And overseas, internationally, you might find that the patient goes on to full life support. So yeah. What are some of the adverse prognostic indicators? So if the patient is submerged for longer than 5 minutes, so we know short is good, we know that more than 25 is bad. If there hasn't been BLS on scene, so if there's been no bystander CPR, if there hasn't been layperson CPR or BLS or ILS crew or lifesaver didn't get there soon, so if it's more than 10 minutes before CPR was started, well, we know that's going to be bad. If you're already having CPR in progress when you arrive at hospital, if the GCS or AVPU is very low, the core temperature is less than 30, or there's significant acidosis on arrival with a pH of less than 7.1, these patients are going to do worse and very well might not recover. They very well might stay in cardiac arrest and demise, or if they came in alive, they very well might demise. So just bear these things in mind if you are exposed to a drowning case. There are some things that can be used for prognostication, and I found this cool tool, the Orlowski tool. It was described in 2012, specifically for predicting mortality in pediatrics. So if you're less than 3 years old, you've been submerged for more than 5 minutes, no attempts of resuscitation in the field, comatose on arrival in the ED and a very low pH. This is then associated with worse prognosis, a score of more than 3. You've got a really poor chance of recovery, only 5% chance. Less than 2 or equal to 2, you've got a better chance. Okay, so that's why I kind of like this one. It was looking specifically at kids. When you're looking at the outcomes overall, what will happen? So we can have a patient that is alive or dead. If they're alive, do they have good cerebral performance and no long-term morbidity? So they might have had a bit of respiratory dysfunction, but long-term cerebral brain function is good and they've recovered from their drowning incident. Or they have morbidity that is related to the hypoxic brain injury. So they might be severely disabled, moderately disabled, in a vegetative state or coma, or brain dead. And remember, brain dead is dead in South Africa. So even if you have a pulse and a heart rate and a BP, if you are brain dead, you are dead. You just need to have made sure that you've looked at all the reversible things and rewarmed the patient before you declare someone brain dead. So these are all of the outcomes of drowning. Obviously, we want someone that's alive with no morbidity, no long-term cardiovascular or pulmonary dysfunction, and a good brain activity. So how do we make sure that we have good outcomes and we actually don't have drownings? Well, prevention is very important. So education is vital. You'll find lifeguards do talks on this. Our community radio station around Rahima, Kafifi FM, they also will have talks and education, and this is a really good talk to give to our community as well. So prevention on drowning, being safe and around water, especially with children, don't leave them unsupervised, recognize distress, and ask someone to call for help, provide a flotation device, something for them to hold on to if possible. Obviously that's really important at the seaside so that they can hang on and they don't have to go underwater. Try and get them out of the water only when it's safe for you to do so, and then provide care as required. So this is all just advice that is given by life-saving associations on prevention of drowning. This is the end of my talk, and I'm going to ask if there are any questions. I would really like if you guys would give me some feedback and questions on how can I improve this talk.
Hi, Tammy. Thank you for that talk. It was really good and really interesting. I just wanted to ask, so based on what you said with the hypothermia, is there no value in doing, I don't know what the correct term is, but sort of therapeutic hypothermia? So I know there are some hospitals that do those things.
Sure. So first of all, you need to rewarm a drowned patient to at least 32 degrees before you call the end of the resuscitation. If you are looking at 32 degrees, 32 to 35, that already is within the target range of targeted temperature management. So we don't necessarily do therapeutic hypothermia anymore. We'll do targeted temperature management where you actually pick a low degree. The main thing in a patient who is comatose, especially if they're post-cardiac arrest, whether it's from drowning or otherwise, is to prevent hyperthermia. So that's what a lot of the post-cardiac arrest and TTM trials were looking at. And actually, there's so much literature that came out since 2014. All the studies in children were done in 2015, 2016, 2018. There's quite a lot of TTM studies for post-cardiac arrest. And the overwhelming thing said, you don't have to aim for 32. You don't have to aim for 34. You must just try and maintain normothermia. So in post-cardiac arrest drowning, if they're hypothermic as well, rewarm them to 32, and then you can look at the hospital protocols of what we're going to target. So at our hospital, we do have critical. It's usually used in neonates, and actually they use it for, obviously, the HIE babies. I've not seen them use it for a drowning, gosh, since I was a medical student, and I don't even know if they used critical back then, but it is an intervention that can be used in an ICU environment to maintain temperature. So much like you can cool a patient, you can also warm a patient with it, or you can just prevent them from getting hypothermic. So we don't want the temperature above 37.5. So we don't warm them up and then cool them down. You'll warm them up until there is a temperature compatible with life, and that's between 32 to 35, and there isn't any consensus on the science yet. That's why there's a range, and all the TTM studies also say there's a range of temperatures you can look at. It's probably easier for us to target normothermia rather than severe hypothermia, because there's also problems with hypothermia, shivering, enzymes, drug dosing, all of those things. So just preventing hyperthermia in the post-cardiac arrest phase is way more important. So if they get warm, you cool them and you target a temperature of 35, 36. Also